So I wanted to start off by just illustrating that they're right. I mean, as gynecologists, we are the ureter predator, so complications happen to everybody. And so I wanted to just talk about one of mine. So one of the cases that I had, this case would have been probably 3 years ago or so. 60-year-old P3 who came to see me for prolapse and stress incontinence. Pertinent history, she developed a bulge in her vagina and also dyspareunia after her last surgery, which was a posterior colpoperineorrhaphy. Incidentally, does anybody know the chances of getting dyspareunia after a posterior repair? Percent? 20. Yep. All right, moving on. Also had stress incontinence with sneeze and a full bladder. So she has some medical and surgical history that was pertinent, but everything else wasn't. So on examination, she had a positive cough stress test. On her urodynamic testing as well as her physical exam, she had, so I just summarized this, grade 2 cystocele, uterine prolapse and rectocele, and her leading edge is actually her cystocele. So our plan for her is that we're going to do a vaginal hysterectomy, BSO, because she's postmenopausal, male-Macaulay caldoplasty, which you'll get to see tomorrow, which is a very intricate surgery, and it's phenomenal when it works well. APR cysto, suprapubic catheter, because she did not want to do any sort of self-cath after surgery. And I offer this to patients who don't want to finagle with the catheter afterwards. They can work with the SPC, and a retropubic sling. So intraoperatively, her uterus did not really descend much past the portion as it was in the office. So it was kind of got to a point it was kind of stuck. So the Mayo vaginal hysterectomy also is kind of an intricate dance of where we start by getting an anteriorly first, make our anterior colpotomy, then our posterior colpotomy, and then you take down your ligaments. And we were actually unable to do that with her because we didn't have enough descensus. So we actually started in the non-Mayo way, which fortunately where I trained, we had so many different general gynecologists that I think I know every single way to do a vaginal hysterectomy, and I've drawn that when I needed. So we started with the uterosacral ligaments. We were able to ligate them bilaterally. Then we made our anterior colpotomy, and we palpated the ureters, and that's part of the Mayo way. So once you make the anterior colpotomy and put in your deaver, you palpate for where the ureters are. We palpated them, thought we were good. Again, thought we were good. Then the cardinal ligaments were taken, and then the urovarian ligaments were suture ligated. Uterus was delivered. At that point, it was, you know what, this was a harder hyst. Let's go ahead and cysto now before we do any of our other sutures. Let's just make sure. And I'm glad we did. And you guys will also develop that little voice that says, well, in my former life, we used to say TSAR, like that stuff ain't right. So you get that little voice in your head in the OR, and you're like, yep, I better check. So we did, and she had no left ureteral efflux. Okay, so on that note, we're going to stop for a second. So what are our options? So you're in the OR, you've done your vag hyst, you look inside cystoscopically, you've given indigo, you've waited and waited and waited, and there's right side spurting like Old Faithful, and the left side's just barfing out at you nothing. That's all it's doing the whole time, and you're like, this doesn't look right. So what do? What are your options? What's the first thing you do? Well, assuming that you're fecally continent, it is a choice. But so just take a breath, okay? Determine, is it something, you know, if you're seeing it violently squirting out the right side, you're sure something's amiss, right? Whether it's ligated, whether it's transected, whether it's just, you know, something else is going on. So the first thing is, do you really have all of her history? So you might want to take that minute to say, yep, you know what, I know I looked at her history before surgery. I know that there's not something else going on. Next steps. What do you think would the next most important thing would probably be to do in your triaging of this is probably not going to go the way that I hoped? Is there somebody you might want to think about calling now that it's early in your day? You still have all the other repairs to do and everything else? So calling urology, like just saying, hey, you know what, can you call the urologist on call and let him or her know that I'm having a little trouble in OR 5, and we might have a left ureteral injury. I have a lot of surgery left to do. The last thing you want to do is mess with this case for 2.5 more hours, then call them in and have them go, we all are done today, or now we're going into a giant, you know, surgery, we can't be available to you. So at this point, you want to check your pulse, take a deep breath, align the team. You guys will call it, what, load the boat or something here? Fine. Load the boat by calling urology, letting the team know, hey, we're having some trouble here. Hey, or anesthesia, we're going to call urology. Think we have a left ureteral injury, but just so you know. What else? So at this point now, you're going to do something. So what are you probably going to start with? I mean, you're not going to just panic. Yep, so what do you think was the most likely stitch that got this? Do you think it was the cardinal ligament? Was it the uterosacral ligament? Do you really, I mean, if you know that the cardinal ligament has your uterine artery in it, are you going to start with that one? Are you going to, I mean, I'm just asking because all of this is reasonable. Cutting your stitches is certainly reasonable, and that's exactly what you're going to do. So, yep, probably start with the non-vascular pedicles first, as much as you can. If you, and these, what's nice is by taking the ligaments down, not in one giant sweeping bite, but in sections, you can be a little more controlled with your bleeding. So the other part is you can actually get to your uterine artery and you can ligate that separately and control your bleeding while you're assessing your pedicles. So that is what we did. We explored the pedicles. So I always take the stitches down, even if it's, you know, at this point, and again, this has happened to me literally twice. So in this regard, it's okay, so you're taking down your pedicles. We found out that there was a left ureteral transection that was identified. So right off the bat, it's okay, what if I could stent her? I mean, if I could try to stent this and maybe there's a way to just put this back together, it was, you know, maybe that's possible. We could not get the stent to go through. So fortunately, my best friend in Grand Rapids is one of the urologists, and so I just called him up and said, hey, Todd, we're going to have some fun in the room. You want to come in? He was like, hell yeah. So he came over and we had fun that day. So at that point, it was, where are you in your case? And I said, we have the uterus out. We have this whole list of things left to do. It's going to take me about an hour and 15 minutes to an hour and a half. And he said, perfect, I've got this thing to do and I'll be right back. So that was kind of our planning phase, and it was, let's just keep going with surgery. So this case ended up getting a psoas hitch. So he came back in, and what we had determined, so the other thing I'll tell you is that while I do not promote myself as a maverick, I have done 3 now transvaginal ureterostomies. They were beautiful. Loved them. All of them worked out great. So do I promote that? Nope. But have I done it? Absolutely. Would I do it again? Yes, I would. And I would do it in the setting that it was retroperitoneal. I had both fresh edges and both ends of the ureter were staring at my face. And it's like, why go through the morbidity of an abdominal surgery if I'm extraperitoneal and I can do this? And I did, and clearly it worked out well. This case, not so much. It was just a kind of a goat rodeo, and we just thought, you know what, this is kind of crazy. But we did do a psoas hitch. So the first thing that you have to recognize is that when you're moving the bladder, you have to try to get alignment of the bladder towards the ureter that's injured. Sometimes that involves taking down some of the connections on the opposite side. So contralateral side stuck, you just bring that down. There's nothing holding the bladder up laterally that you have to care about really, other than the vessels, but they're usually not much of an issue. So you get mobilization towards the side that you're trying to do your ureteral reimplantation. And on this side, when you're doing that, now they're showing using a Bovie. I'm not a big fan of Bovie on the bladder, only because I want my vascular edges to be well perfused and I want my repair to go well. But nonetheless, so we did the psoas hitch by, you can do a transverse incision, and then when you pull it up to that side, it becomes a vertical incision, and that's kind of a cool plastic surgery trick. And then extending it out, so you want to make sure that the incision you're making also allows the bladder to reach your ureter, because you feel really, really dumb if you poorly plan your incision and then you get all that mobilization and you still can't attach the ureter to where you need to go. The psoas hitch can be really good because you're taking the tension off the ureter. Do you have to do this with a ureteroneocystostomy? Absolutely not. You don't have to do a psoas hitch. But in this regard for this patient, we just didn't want the bladder and the ureter to have tension between them and risk the reanastomosis. So you can see that on the number 10 picture, what you do is put a stitch through the very distal end of your ureter, and then you can use the clamp to grab that stitch. Much less trauma to the ureter than by grabbing the ureter itself with the clamp and pulling it through. You want to pull it actually into the bladder, and you'll see that they feed their stent through your cystotomy, which makes sense, rather than doing it cystoscopically later and messing with it. It's just kind of make your life easier. You affix the ureteral orifice now into a new position, and you're going to use very small absorbable thread suture. So I usually use like a 4/0 or a 5/0 Vicryl. You can use monocryl. You can also use chromic, something that's going to be really small. When I worked with Gynonc in Grand Rapids, they use Vicryl all over the bladder, and I got into the habit of using chromic in the bladder because it heals so quickly. So we would always go back and forth about, you know, what a poor decision it is to use a braided Vicryl suture in the bladder and how smart I was to use chromic. It was a great little debate. So you have your double J stent that's then placed, and then you can see that they're fixing the bladder to the psoas fascia up in picture 15. And you don't want that to go into the bladder, so just through the muscularis of the bladder itself, not into the into the mucosal layer. And then they put in 2 suction drains, as you'll see over here. and closing the bladder in 2 layers. So I do recommend closing the bladder in 2 layers. You want a watertight seal. I do not recommend challenging that repair because at the end of the day, you're leaving the bladder to drainage anyway. So there's no reason for you to go in and stretch all your repair out by filling the bladder with 500 cc's when it's going to lay there passively healing. And the bladder really does heal quickly. So this is what that looks like. So the plan for the patient was that she would get a retrograde cystogram 6 weeks post-op and that the stent did actually come out because she had no extravasation. The drain remained in her until discharge. She had 1 drain, and it came out upon discharge. And then she had close post-operative follow-up, so we were seeing her weekly, and then she was supposed to take daily temperatures. She came in for an incision check at 2 weeks post-op, was doing great. Came in at 6 weeks, everything looked great. Incidentally, we did do her sling, we did do her repairs, everything else went well. We proceeded with the rest of the case like we normally would. There were no other intraoperative issues, and she healed up beautifully from her surgery. And had no issues with voiding dysfunction and did have the retropubic sling. All right. The Foley was in for 10 days. Yep. All right. So, as I said, complications happen to everybody. The important thing, and this is one of the reasons why I love surgery, is that I feel like it's a manageable amount of risk, and so you kind of know what you're going to do at each step. This sucks, and as Dr. Rice said, this makes your stomach hurt so bad. Even if you think you have a ureteral injury, you just want to vomit because it's so frustrating, mainly because you know what that's going to do to the patient in terms of their postoperative risks, and it just kind of sucks when things don't go the way you want them to. So overview of this lecture, we're going to review urinary tract anatomy and the relevance to gynecologic surgery, discuss incidence of and risk factors for urinary tract injury, and describe management strategies of various injuries. So I am a huge, huge, huge fan of pelvic anatomy understanding, and I feel like we do a disservice to our residents and fellows by not having a set pelvic anatomy course, which is something that I've been a proponent of in looking how I can contribute here. So this is a patient actually who would be in lithotomy. So that's the orientation, which I'm assuming you guys think the vagina is facing you, you should recommend or should recognize she's in lithotomy. But this shows, again, how closely everything is. And you can also appreciate when you're looking at things as a mid-sagittal section, say in netters, and you're kind of seeing the orientation and everything tends to be horizontal and you're thinking, this is great. What about a patient, when she's lying down? That's what this looks like. See, and again, everything's all beautiful and big circles and huge. It doesn't look like, you guys know it doesn't look like this. But this is how you can see, the pericolpium, where the ligaments are, and how the ureters are going to be running in and plugging into the bladder and touching all these beautiful structures that we play with every day in the OR. So the bladder has various components, as I know you all know. So the detrusor is a network of intertwining muscle fibers. It's the contraction of the bladder that is beautiful, but the bladder is a beautiful organ that lies there passively and just takes it all day long with all this urine coming in. 2 main areas of blood supply, so there's the superior and inferior vesical arteries, and then the internal anatomy really just can break it down to the dome and the trigone. So here's a bladder in case you guys have never seen one before. All right, and this is just a cross-section through the wall of the bladder, which again, I know you know the pieces. This is just more kind of a cerebral exercise. All right, so for ureters, they're about 25 centimeters long. It's a tubular viscus. They course over the division of the iliac arteries, under the uterine artery, lateral to the lateral vaginal fornix, over the vaginal artery to the posterior superior angle of the bladder, and then enters the bladder wall. None of this should be new information for you people. The ureteral blood supply is unique. It's parasitic, actually. It has multiple areas where it gets blood supply. One could theorize because it's so super important. One could just theorize that, embryologically, those things developed in the same location, so it just kind of held on. This works to our advantage a lot of time when we're looking at, do we need to reimplant a ureter versus reanastomose a ureter? What's our plan? You have to remember the blood supply and know where it's coming from. This is also the reason that when you do a ureterolysis, you'll see people leave a lot of the adventitia on the ureter rather than just skimming right along the ureter as well. You don't want to devascularize it. So abdominally, the ureter receives its blood supply from the medial portion and laterally from the pelvis from the lateral portion, which makes sense, right? Because your vessels expand out. So again, a nice little picture. I steal from Nutter all the time. I'm going to disclose that. You guys can do whatever you want with that. But so you can see where the ureter is in relation to the vasculature and to the organs. And as well here, and I did try to make these a little sharper for you, so I hope you can appreciate that. And then this is what it looks like looking down into the pelvis. So again, ureter's pretty close to what we're doing. And so when you're doing a hysterectomy, like you'll hear the consultants and attending saying, you know, keep your clamps right on the uterus, slide off when you're closing them. And that's part of the reason is that when you get really excited and think you're just kind of making some space, you're more likely to get the ureter. And this is a posterior view. So you can see the uterosacral ligaments on the bottom of the uterus, and then you can see where the ureter comes in from the uterine artery. So urinary tract injury, and whatever resident did that talk this morning was right on with what she was saying. So we've got a risk of urinary tract injury, so bladder injuries, depending on the route of hysterectomy, roughly 0.5% to 1.5% chance. Ureteral injury, depending on what article you're reading, it's a 0.4 to 2.5% chance with benign pelvic surgery cases. Now, looking at whether or not you do cystoscopy, so you guys are too young to maybe remember, but universal cystoscopy during hysterectomy was not routine, always, right? So this is something that's relatively new. So wonderfully, if you never look for it, you have a far less chance of hurting the bladder and ureters. Like, you just don't have to think about it, right? So we shouldn't look. We don't hurt them if we don't look at them, right? It's like avoidance is key. No. So this was a really nice study done by Matt Barber and his team at Cleveland Clinic looking at the risk. So I will give you one caveat though. This is true for cases where they're not using electrocautery. So once you're using electrocautery, cystoscopy isn't as good at picking up injuries because they tend to occur late. So that's like my one little exclamation point for that. And then it's higher for invasive cancer and urogynecologic surgery cases. So most cases do not have a identifiable risk factor, as in my case. Why did a uterus not come down as much as I thought it would? Well, that's just the way it was. I mean, Carl Podratz was my mentor at Mayo. Love that man more than I love air. And he does a technique in his vaginal surgeries to help kind of stretch the uterosacral ligaments. Tried that. It literally did not budge at all. They were like made of cement or something. There can be a disruption of normal anatomy. So you guys see a lot of the general OBGYNs, urogyn, gyn-onc dealing with a lot of these things. Pelvic malignancy is present in 44% of ureteral injury cases. Whether that's because of previous surgery or radiation, doesn't matter, but those things contribute. So 75% of ureteral injuries occur during gynecologic surgery. So we are the ureter predators, as I said, right? 75% during abdominal surgery, and only a third of them are recognized at the time of surgery. So why does this happen? Well, there are really 4 places where you can get the ureters. We've already talked about their course. You can get them when you're going after the gonadal vessels. You can do it as well when you're ligating the uterine arteries. Also, maybe you didn't think about this, but when we're doing our anterior colporrhaphy, or we're doing any dissection between the vagina and the bladder, like a colpochlesis, this is another place that we can get them. And then when you're doing lymph nodes. So these are the 4 areas. So, I mean, when you guys are in the OR, kind of think about where the ureter is coursing, and I'm hopeful that you're optimistic about the people you're operating with, but do recognize that, you know, the more you guys are watching and learning and thinking about where you'd put your clamps and where you'd put your sutures and why did they put it that way, be actively involved even if you're just observing. So stents. People will often say this, like, we're going to stent her before surgery. There's actually no proven benefit that this avoids a ureteral injury, but it can make an injury easier to see because a piece of plastic sticking out after you cut through something is not normal, so it can tell you, hey, this is not right. However, be aware that there is a risk of injury to the ureters when you place stents. So if you have a 2.5% chance of injuring the ureter with placing a stent and you have a 1.5% chance of getting the ureter with your surgery, you have to weigh that out and say, am I really doing any benefit here? So routine use is not recommended, which again is probably why you guys don't see us doing it in everybody, but there are times it can be beneficial. So if you think you're walking into a case where, you know, this is going to be a real problem for me, it is reasonable to have, if you guys are going to get, depending on your field, get privileges for placing stents, it's fine. Otherwise, you can have urology do it, and they're usually pretty open to helping out with that because they'd rather put them in empirically than have to come in later and spend 2 hours doing reanastomosis or reimplantation. So diagnosis of urinary tract injury, we kind of look at this as an intraoperative recognition or post-op, and post-op can be acute or delayed. So intraoperative recognition, if you're doing transabdominal surgery, you can dissect the ureter down to the bladder. You can also do an extraperitoneal cystotomy and just look to see if there is any urine that's effluxing through the ureteral orifice. You can do cystoscopy with or without stenting, or retrograde filling of the bladder if that's a bladder injury. And during transvaginal surgery, you're really limited to cystoscopy with or without stenting, or retrograde filling of the bladder to look for a bladder injury. Post-operative recognition is a little more complicated, so obviously taking the patient's history, that's key. You want to do a physical examination. There are various images that can be obtained, whether it's through ultrasound, IVP, CT urogram, or do a radioisotope renography, which could include a MEG-3 scan or a DTPA. So we'll talk a little bit about these, but I have some cool pictures that I just wanted to show you, and you guys have probably seen this. But what I would say to you is, so nuclear medicine is great for function and not great for anatomy, whereas the anatomical scans like ultrasound and IVP and CT urogram are great for anatomy but not great for function. So if you're concerned about renal function, you're probably going to be looking at a nuclear medicine scan. If you're interested in anatomy, you're probably not going to get a nuclear medicine scan. There's no point in exposing the patient to additional radioisotopes if you don't have to. So here's an ultrasound showing the bladder in a transverse position, and unfortunately, this picture's not great because your arrows are like right in the midst of these huge dilated ureters, but I think it just shows you that you normally probably don't see ureters on ultrasound very well. I think we'd all agree that that's not something you really normally see as these giant eyeballs under your bladder that are staring at you, but that's what this would look like. This is a normal IVP, and here's an abnormal IVP. Which ureter do you think is the problem? Right one. So you have your calyx is dilated on the right side. So this is showing what that would be like on the left. If you had a ureteral injury and a functioning kidney and it was a complete injury. And this is an abnormal CT urogram, so this is the left side as well. So here's an example of a normal Lasix renogram, and you can tell that it's normal because so I did a month away rotation at the University of Washington in nuclear medicine, and I loved my time there. It was awesome. Satoshi Minashima was my mentor who was there, and he's pretty incredible. And so what he always said was, we don't want people reading the images because, again, it doesn't really tell you what the function is. But there's a nice little graph at the bottom. So the graphs are roughly equal. Kidneys are functioning equally well. That contrasts to this, where if you look at it, you can see that the left side's lighting up and everything's good, but the right side's not really doing its job. So you can see that the right side is more delayed. So, and this just shows the actual kidney portion. So when they check the radioisotope, you can see there's a greater uptake on the left. And this is a MEG-3 renogram. So again, you're seeing that the patient has one functioning kidney. Now this is really important because if you have a delayed injury and you're trying to decide what to do about it, it's probably important before you run back and do some crazy huge surgery on her. If you find out her kidney's dead, what's the point? I mean, the goal of all of this is to maintain normal renal function. So if you've already lost the kidney, you're kind of just done. So what is this? What do you guys think this is? What do you see? So what's the image on the right? What's C, what's B, what's D? You guys are smart. Come on, speak up. We can't hear you. So which part's the vagina? Okay, and what's B? And what's C? So what's going on? Okay, so it could be retrograde. What do you see going on your... Yes. Okay, and based on what you're seeing, what do you see on the picture on the left? Between what? So actually, this is a ureterovaginal fistula. So you have a dilated ureter, contrast in the vagina, and with the contrast going into the bladder as well, you have one side functioning and one side not. So this is actually, so obviously you recognize it's a fistula. Something's not right. You shouldn't have contrast in the vagina. I mean, even the world's dumbest retrograde filler shouldn't have contrast in the vagina, that much contrast in the vagina. So obviously something's not right. All right. And that does happen. Yep, that does happen. Yeah. Yeah. Yeah, I don't know what's happening. This is so confusing. Yeah, no, yeah. Left to their own devices, people will do some funky stuff. All right, so management of acute injury. So let's just say this for a second. So you get a bladder injury. So you guys are doing your surgery and you are cutting something. You're like, oh, geez, I think I got in the bladder. So the first thing is that, yep, you identify that as a bladder injury. Just, put some suture in it, near it, whatever. I usually use silk because it's something permanent, something that I can find easily. Tag it long, or not tag it, but cut it long so you can find it later. And then continue with the rest of your case. Why would I do that? Like, why am I not freaking out and fixing it right away? Exactly. So I can actually use that cystotomy to guide the rest of my dissection. I mean, do you know how many times I've had something difficult that I've had to do and I stuck my finger in my cystotomy and it's aided the rest of my dissection and I've avoided 3 or 4 more bladder injuries? So you can use that. Now, the other thing I'll caution you on is that the bladder is beautifully forgiving. It tears like wet tissue paper. If you're rough with it, your cystotomy will just get bigger and bigger and bigger. So you do want to be aware of that. As I said, always close your defects in 2 layers. 3 on the bladder, or 3O chromic or Vicryl is fine. I often use 2O chromic on my bladder just because, again, I like chromic because it goes away fast. Drain the bladder for 7 to 10 days and then 6 weeks if there's previous radiation. So a ureteral injury repair, and this is what we talked about, it depends on the cause, location, and extent. So if it's a minor trauma, which ironically, I wouldn't think a crush is a minor trauma, depending on your clamp. I mean, I use Haney's and they're pretty, robust little clamps. But anyway, you can just use stent and drainage. If there's a partial transection, you can also use a suture repair. If it's in the lower third, a primary ureterostomy can work, as can a ureteroneocystostomy, and a transureterostomy if there's extensive urinoma or pelvic infection. Mid-ureter injury, primary ureterostomy or a transureterostomy, which is not common. Or you can use a Boari flap, which I'll show you a picture of. If it's the upper ureter, you are never, ever, ever going to know my name with this, but an auto transplant the kidney or transposition of bowels, because again, that's a pretty bad injury to the ureter, and you don't want to have that not be a hole that closes. So that doesn't happen often. But anyway, so a Boari flap is different than a psoas hitch. And a Boari flap, to me, when I think about these, I think about it in terms of where the ureter is damaged. If you have a high injury, the Boari flap can be beautiful because you can make a flap and you pull it up to where you are and then you roll the wall together to make another tube. And then when you close it, you have a longer line. I've done one of these, and I did it when I was on Gyn-Onc as a fellow. It worked out beautifully, and I was like, this just seems so much, it's just so much work for this whole repair. But it was our only real option because of how high the injury was. She had a ovarian cancer, a debulking, and it was just a complete goat rodeo. But anyway, so the transvaginal ureterostomy. I don't know if you guys know despair.com, but keep living life like there's no tomorrow, and you'll be right sooner than you think. So again, select cases, urology's blessing. It's all extraperitoneal. I'm very confident in where we are. The ends are fresh. They're both staring at me. So the little 10-second story is when I was a fellow. The first case I did was when I was a fellow. I was doing a vault repair. I transected the left ureter. Had the situation. So at Mayo we have SAs, surgical assistants, who are like, they should be surgeons. They're so amazing. And so Mike was my SA, and the consultant was in his own room, and I was in my room. And so he's like, just fix it. I'm like, great idea. I fed the stent in proximally, fed the stent in distally, then repaired it. Beautiful repair. My consultant walked in, looked at it, and said, take it down. So I took the whole thing apart, everything apart. He put on the camera, he videotaped himself doing everything I had just done, sent the video in, and he presented it as a poster presentation at one of our meetings. And a urologist walked up, and when he was at the podium, and completely ripped him. I mean, talk about fecal incontinence, he got ripped. But I do think that in this regard, when you recognize that you have the makings of a good outcome for this patient, that you're not going to risk something, obviously, and then very close follow-up. So would I do it today here? Probably not. I mean, I would have urology come in, but if we are able to do it and that was something they would support, I would do it. So timing of injury, late recognition. So these patients generally present, they're either really, really sick or they're really, really wet. And either way, they're really, really mad. So it's really important to recognize that you could be seeing a patient with a fistula. She could have hydroureter or hydronephrosis, a urinoma, urosepsis, ileus, or a fever of unknown origin. So if any of these things are going on, you got to start thinking that there must be something going on with the ureter or the bladder, but usually the ureter. So what do you do? What are the next steps? So if there is a potential fistula, so these are patients, and depending on the presentation, you'll get some suggestions as to what the problem is. So as an example, a patient who is wet all the time and never has an urge probably has a vesicovaginal fistula. A patient that is wet intermittently, maybe more so than not, but intermittently, and still voids normally, probably has a ureterovaginal fistula. So asking her those questions and being very detailed and drilling down to what is exactly making you wet. Are you dry? Are you dry constant or wet constantly? Are you dry maybe at night when you stand up you get this gush? Like, kind of will help you to understand that. But once she comes in, there are a couple things you can do. So if her history is such that I'm really suspicious for a vesicovaginal fistula, you can do the tampon test in the office. You can use methylene blue, instill it through the Foley into the bladder, and then see if the tampon comes out blue. If you think at all like either the history is unclear, or I just want to rule this out because I'd hate to miss another urinary tract injury, you can give her pyridium ahead of time. Then you can do the tampon test, and you can determine if there's orange coming out. It would be ureter then, or bladder if you had a lot of leaking. So that it can be where it is tricky if you have a really bad fistula and she's got orange and blue, and you're wondering, is the orange there because she had the pyridium ahead of time? And so it can get a little tricky in that regard. You can, I'm sorry? Oh, yeah. You can also do a retrograde cystogram, a CT urogram, and then the initial management again. So, and this is where I'll say, I mean, I've handled all of these things on the behalf of other gynecologists, but so if you have a patient with a ureterovaginal fistula, you can do stents, and you can do them either retrograde or antegrade. If you have a patient with a vesicovaginal fistula, which we'll talk about in a minute, you can manage with drainage. So I had a really cool case for me, really sucky case for the surgeon, but there was a general OBGYN who he did 3 surgeries. All 3 that day had some degree of ureteral, bladder, and gynecologic involvement, and I took on all of them at various times. So the 3rd case came to me that night, which I operated at 11 o'clock at night. The 2nd case came to me a week later, and the 1st case came to me 2 weeks later. So the 3rd case was a ureteral injury recognized intraoperatively that was transected, and she was sent to me. The 2nd case was a patient with a ureterovaginal fistula who came to me a week later. So that patient, we stented her. She had a right ureterovaginal fistula. We stented it, and what was interesting is that she also had a PERC neph tube because we felt like the stent wasn't actually going to drain her very well, and she had a fairly high degree of hydroureter. So she had a PERC neph tube and a stent. The stent was siphoning the urine off of the left side, so she never peed the entire time that she had the stent placed. So she was actually pulling everything out from her bladder, from her right or from her left kidney into her PERC neph tube. So it was kind of interesting. She's like, I'm not peeing. I'm like, what do you mean you're not peeing? She's like, I'm not making any urine, but her output was like 2 liters a day from her PERC neph. So like I said, it was one of those where you're like, how is this possible? It was crazy. But anyway, you want to make sure the goal again is protect the kidney. So whatever the issue is, protect the kidney. So if you have a bladder injury, it's keep the patient dry. Kidney should be fine. So with a vesicovaginal fistula, so here's some really cool information. So normally what we would have said to you is you want to delay the repair. Why do you want to delay the repair? Like if somebody came in and they're like, okay, I'm a week out, I know I have a fistula, I want this fixed right now. What might be reasons that you're going to say, no, we can't do this right now? Exactly. So if you have a lot of inflammation in that spot, you don't want to take her back to OR. How many times have you guys reoperated a C-section and have looked at your hysterotomy that you repaired and you're like, oh my gosh, it looks like ground beef mixed with pus, like this is just nasty. It's hard to operate on those fields. But what might be another reason that you're not going to operate right away? Exactly, could heal. And so then you save the patient a surgery. So our typical approach is that when a patient comes in, you want to identify where it is, where's the proximity to the ureter, where is it located within the vagina, always thinking, how am I going to fix it? But then basically, can you let it heal? And that's the hard thing for patients is they might want to just, because in their mind, it's if you do surgery, I mean, you're going to fix this and I'm going to be dry. And then I'm never going to come back and everything's perfect and my life is great and we're all good. but that's not the case. So you can drain her, you can wait. What I tell patients is that the you want to assess for ureteral patency and kidney function. So if a patient's coming in and you have one GU injury, you could have another GU injury. It's not unreasonable to look for that and say, hey, you know what, we need to make sure that we're protecting you overall. So vaginal repair is the primary management, and this does differ depending on if you're a urogynecologist or a urologist, because urologists love to be in the belly, and they really, 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 really love their $1.5 million robot. So they want everyone to have a belly surgery because they get to play with the robot. I prefer to look at this as we have a hole between the bladder and the vagina, and I would say 99% of the ones I've fixed have all done vaginally, and all but one did great. So, I mean, at that point, it's, I'm very happy with that. So in the literature, about 80+% of them are successful. I would go through the abdomen if it was a large or complex fistula, depending too on its proximity to the ureters, although that's not always recommended. You can still do a vaginal repair. Or if there's inadequate exposure. So for example, one of the patients I did a vaginal repair on was over 400 pounds. That was not an easy day. That was not a day that Dr. Heisler didn't say swear words. So it was a little challenging, but she did really well. So, and I did not want to go in a 400-pound woman's belly. If you have a hydroureter or hydronephrosis, again, you want to look for where are they obstructed and does the kidney still work. So this is where you're going to look at nuclear medicine imaging and assess the kidney function. Again, you still want to drain her, and you still want to get rid of that. So you probably partner with urology. You get either retrograde or antegrade stents placed, percutaneous nephrostomy tubes, and then ultimately she'll probably be getting an exploratory laparotomy with some degree of reimplantation. And then a ureterovaginal fistula, and I have taken care of a few of these and done their surgeries. So the primary management is ureteral stent placement. The one that I told you about, that the stent was siphoning off the urine output from the left side, she actually healed spontaneously. It took a long time, but the urologist and I were committed to helping her with this, and she was dry, so she wasn't leaking vaginally, and she wasn't, of course, having an urge either, but she did great, and she actually healed without additional surgery. I took care of another patient who had a complex, duplicated left ureter, both ureters and the bladder pulled in together during the repair of her cuff with a leiomyosarcoma. So she had a complex uretero-vesico-vaginal fistula that we took care of. And while she did great from her surgery, she eventually succumbed to her disease. So you want to make sure the kidneys are functional. You want to make sure that you're protecting them. Usually it's an abdominal approach, and ureteroneocystostomy is what you're going to be doing with or without a Boari flap or psoas hitch, just depending. So when they're sick, and they get sick fast usually from this, you want to pull in ICU as much as you can, protect the kidney. You want to see where this is all happening, and you are not likely managing any part of this. This is urology and ICU, and you standing on the sidelines, hat in hand, like just supporting everybody. So these patients get, like I said, they get sick fast. So in summary, you want to know your pelvic anatomy, which I know everybody, I'm sure in this room, thinks they're very good about that, and you probably are, but just a review of it's not inappropriate. You want to make sure that you have a thorough intraoperative assessment of the urinary tract. So again, if you're doing a lot of robotic or laparoscopic surgery and you're using a lot of electrocautery, think about thermal injury. If you think you're close, be very cautious. Maybe see those patients in close follow-up, have them taking temps. Don't just let them go and assume you'll hear if something is not going well. Also, timely management of postoperative urinary tract injury is paramount. You want to focus on minimizing morbidity. I mean, an angry patient is better than a dead patient, so you want to be able to partner with her and help her and support her the best that you can. Being in my role, I've been fortunate that not only am I bridging the communication between the primary surgeon and the patient, but also like helping to have the patient make sense of what's going on and how we're going to help her. So it's been, it's an honor to try to help, because usually the gynecologist is pretty upset this has happened and they want to be involved, but they feel very helpless. And so it's nice to be able to say, I'm partnering with you to take care of your patient. Lastly, this article just came out 3 weeks ago. I do have it if you guys want it, but I saw this and I'm like, well, hot damn, I could have just handed this to you people and we could have gone out for pizza. So anyway, if you guys want to take a peek at that, it's laid out a little bit differently, but I think it's a nice, succinct article to keep on hand. So as you guys are going through the rest of your residency or onto fellowship or into practice, I think this is a nice thing just to have as a resource. So you guys know that it's there. These are some of the references, all of the pertinent ones, I think. And then thank you. So we do have a little bit of time. I knew we'd be done early, so I wanted you guys to wake up before we started. Do you guys have any questions that I didn't answer or things that you always wanted to know and you finally had me to ask? Well, I don't. Urology does. But that they go through the percutaneous nephrostomy tube. So they put the tube in and then they put the stent through that. That one? Yeah. Yep, I'd be happy to send it out to you guys. Yeah, it's hard to get actually because when I was on PubMed, it doesn't come up as a PDF. So I actually had to go search for it and get it because it's ahead of print. So it was a little bit of a pain in the patootie to get. So now that I have it, I'm like, I can get it to you. Like, don't waste your time. It took me forever. But yeah. So I don't give out my slides. I will give out individual slides for necessary things, but it's intellectual property. So it's my standard expectation that I don't, and you should be very careful of that too, just moving forward. But if there's something specific you want, I will share individual slides if requested, but I